Request Dr. Basak to start with his talk, if possible, sir.
Yes, no problem.
Because I think
There are other persons who are also there, not to be judged.
yes. So you are also one of them.
Start those videos. I
Yes.
think that is the best. By that time, other
Yeah, that's the idea,
Yes,
sir.
sir.
That's the idea, sir.
Thank you, sir. No. So we are starting off with the video by Dr. Samar Basak.
As I
And-
said that this, I have won CS Reshmi in I think 2001 or 2000 might be. So this has not to be judged. This is
Yes.
for to showing some work of mine.
So he is going to present on the BCL interface technique of DMEC graft preparation, doubling the utilization of during the COVID in pandemic. Please, sir.
We'll play.
No, the videos are already timed.
So no timing.
There's nothing like that. The
No
video is
time
as per
already.
the
Nothing.
All
It's already
set.
timed, so don't worry about that.
And then Dr. Shubhendu Bodal is there from retina section. Is from our. He is also here. You can play his video. He has already won the CS Reshmi. He's here.
So you are also not to be judged. Okay. So we can start with the sessions which are not to be judged. So we have saved time
No, no,
also.
no.
And
The
by that.
sound kahan?
Please put the sound and
Start from
the sound and start from the beginning, please.
Stricter donor selection criteria have reduced the overall donor pool by 40 to 70% in different eye banks globally, including our own. The COVID-19 pandemic has affected all areas of medicine, including eye banking. Stricter donor selection criteria have reduced the overall donor pool by 40 to 70% in different eye banks globally, including our own. However, the demand for keratoplasty remains the same. So we need to be wiser so that we can double the utilization rate. Most practically, using the same donor tissues for DMEC and DALC. Here we describe a novel BCL interface technique of donor preparation in DMEC so that the anterior part can be used for DALC. We have no financial interest in this video. Conventionally, most surgeons use a stamped DMEC graft for ease of orientation during unscrolling. To make that, we need an S or an F stamp on the DM side during donor preparation, which is done through a 3 mm stromal window. And naturally, after the window is made, the anterior part of the tissue cannot be used for DALC or other surgeries. In the novel technique using BCL interface, we modify some of these steps. The tissue is first placed on a Teflon block with the endothelial side up, and a 9.5 mm partial trephination is done. It is then stained with trypan blue to identify the cut margins. The peripheral DM beyond the trephination is then stripped off. The DM endothelial edge is carefully identified and loosened all 360 degrees with an elevator instrument. Then, using McPherson forceps, the DM graft is gently peeled from the stroma almost entirely, leaving behind a 1 to 1.5 mm hinge. We then move to a second Teflon block where a BCL is placed and refined to 12 mm. Trimming it down to size helps in better air trapping. A 3 mm central or slightly eccentric punch of the BCL is done. The trimmed BCL with central window is again stained with trypan blue for easier identification. This is then placed onto the stripped part of the donor corneal stroma. Very carefully, the stripped DM endothelium is floated back on the BCL surface and the water soaked to prevent it from slipping. The hinged part of the donor graft is then separated and the entire DM endothelium graft is gently centered on the BCL. The interface fluid is soaked so that the graft sticks to the BCL due to surface tension. Now the BCL supported tissue is flipped over and air is trapped so that it doesn't collapse. The exposed descemex is dried carefully through the 3 mm window and the S-stamp is placed as usual. The BCL and DM complex is flipped back. It is then placed on the second Teflon block with the endothelium side up. And now the final 8 mm trephination is done. The DMEG graft is carefully transferred to the cup of the donor tissue and stained with trypan blue and subsequently washed with BSS. The stamped graft is now ready. It is then transferred to a Petri dish containing BSS, ready to be loaded into the injector system. The remaining anterior part of the donor tissue is then kept back in the preservative media, which is now ready for donor preparation in DALC surgery of 8 to 8.5 mm graft. Since the faint 9.5 mm from the initial partial trephination is already there, harvesting up to 9.5 mm DALC graft is possible, and there is no need to do descemex endothelial removal in this case. During the past pandemic-stricken year, we have used this BCL interface technique in about 40 donor tissues, 17 of which were used for DALC. The other cases, the tissue was used for tectonic, large therapeutic grafts as a globe-saving procedure. The key steps for this BCL interface technique in DMEC graft preparation are: complete 360-degree loosening of the DM with a fine elevator-like instrument, peeling of the DM endothelium complex up to 90 to 95%, which is more than what is done conventionally, sizing of the BCL to 12 mm for better air trapping, central punching of BCL with a 3 mm trefine, placement of this windowed BCL between the stroma and then careful flotation of the DM endothelium over it. Good centration of the DM endothelium over the BCL. Soak the interface fluid, flip the BCL supported tissue, dry the DM surface and give the S-stamp. Final 8 mm trephination. Which is then transferred to the anterior stromal donor tissue cup. And then finally staining with trypan blue and transferring it to a Petri dish. Apart from DALC, the remaining tissue can be used for tectonic grafts, large therapeutic keratoplasty, or even as a carrier for a Boston type 1 keratoprosthesis. Thank you for watching. The COVID-19 pandemic as a
Wonderful video, Dr. Bashar.
Thank you very much.
Yeah. Any questions from any of the judges?
We have published this in Cornea Journal last October or November. It has been published in Cornea Journal as an innovative technique.
Great, sir.
Thank you very much.
Indeed. Thank you very much, sir. Thank you.
He has been consistently been selected in the finals for last 12 years probably, and It is an honor to have your videos seen here in every session, sir. Thank you so much.
So I would suggest if anyone really wants to learn the nuances of making a good video, Dr. Basak always stands out to be one of the guiding light for all of us. And looking at his videos, precise to the point and how nicely it is made with a subtle background and everything are all the points that we really need to learn from him, and really well made video. So now we move on to the other giant from Calcutta who has been consistently producing superb retinal videos which have won even at the level of the American Society of Retina Specialists. And it's a pleasure to welcome Dr. Shubhendu for presenting his video.
Thank you.
Can we increase the AC please? All of us, someone in the... There AC koi bada sakta hai? It's quite warm.
Light?
Not to be
Light.
To touch or not to touch.
Light off.
We have no financial interest to discuss. Falciform folds are congenital tractional retinal folds due to strong tractional retinal forces and hyperextensibility of retina. This results in temporal dragging of macula and vision loss. Occasionally it is associated with familial exudative vitreoretinopathy. Even the hardcore VA surgeons are often reluctant to touch these cases. This video demonstrates a novel innovative surgical technique to remove both preretinal and subretinal adhesions to unfold these folds. 43-year-old male presented with dimness of vision in right eye since childhood. In left eye, it was for last 1 month. In right eye, there was a falciform-shaped fold extending from the disc towards temporal periphery with temporal dragging of macula and a small fundal coloboma just temporal to the optic disc. In left eye, there was fovea on temporal retinal detachment. The plan of surgery in right eye was vitrectomy with ILM pilling with injection of balanced salt solution subretinally and sulfur hexafluoride gas tamponade. In left eye, vitreoretinal surgery with silicone oil tamponade to settle retinal detachment. 25 gauge vitrectomy was done in right eye with removal of all preretinal vitreous bands and tractions. ILM was stained with brilliant blue G dye and peeled in a patchy manner as it was very stickily adhered to the underlying retina. ILM peeling was also carried out over and around the falciform fold. Diamond dusted membrane scraper was used to do gentle rubbing over the wrinkled macula to flatten the fold. Then a 38 gauge polytip needle attached with a VFC syringe filled with balanced salt solution was used to inject BSS subretinally. It formed blebs at multiple locations around the falciform fold. The subretinal BSS would stretch the subretinal space to remove subretinal adhesions in this long-standing fold. Finally, presence of any peripheral adhesions was checked again and air fluid exchange was completed. After 3 months of surgery, the fold at the macular area was narrowed down and almost flattened. Vision improved to 20/80. Left eye retinal detachment was treated with vitrectomy, PVD induction, internal drainage, barraging all lattices and breaks, and silicone oil endotamponate. Post-operatively, final vision improved to 20/30 after removal of silicone oil in this eye. So much about the promising result, but my previous experience in a similar case was quite disappointing. Operated on a 11-year-old girl who presented with counting finger close to face vision in right eye and an elevated temporal falciform fold. Her left eye was absolutely normal with BCVA 2020. The same surgical steps were performed: vitrectomy with ILM peeling and submacular BSS injection and SF6 gas tamponade. But she developed macular hole with retinal detachment after 2 weeks. I had to repeel the ILM to use free ILM flap to close the macular hole under silicone oil. Finally, patient achieved 2080 BCVA after phacoemulsification with silicone oil removal and complete flattening of falciform fold with attached retina. A third challenge presented with 33-year-old one-eyed female patient. Her vision in right eye came down to accurate PL and PR levels for last 5 days. Her right eye cataract was advanced. A combined phacoemulsification, IOL implantation along with vitrectomy was done. There was familial exudative vitreoretinopathy with temporal falciform fold with total retinal detachment and mild vitreous hemorrhage. Vitrectomy was going on uneventfully. Suddenly the detachment became bullous. I realized my infusion cannula tip had gone subretinally. I ensured that the infusion cannula tip remained inside the vitreous cavity. Did a small retinotomy superiorly to decrease the bullous nature of retinal detachment. Removed triamcinolone stained vitreous schisis membranes. Injected heavy fluid PFCL and removed all vitreous. Peripheral circumferential retinectomy was done for redundant retinal fold and air fluid exchange started. Injected more PFCL beyond the retinectomy margin to flatten the retina. Then I used a Flex loop to unfold the residual retinal fold as much as possible. Finally, laser done around the retinectomy margin and all around periphery. PFCL removed and silicone oil injected. Post-operatively, the retina was attached and flattened. After silicone oil removal, patient gained 2200 base corrected visual acuity. So to unfold the falciform fold, things we should remember. There are both long-standing pre- and subretinal adhesions. Pre-retinal adhesions can be released by vitrectomy, adhesion removal, ILM peeling as well as mechanical stretching by Thanos scraper or Flex loop. For subretinal adhesions, inducing subretinal stretching by injecting BSS subretinally, but it should be done away from fovea to avoid macular hole formation. Our innovative surgical approach in these extremely difficult cases may help to recover satisfactory vision. Thank you. Unfolded falciform folds.
Thank you, Shobhendu, for fantastic 2 cases shown to us. Just one question.
Yes.
Do you think how crucial is ILM peeling, or is the ILM fold as important, ILM to be removed for unfolding it? Can't we do without it?
Basically, our old belief was there is nothing can be done in this kind of eyes. So when I faced few like one-eye patient or some patient with very compromised vision or patient are willing for the surgery, then you should go do something like what to be done. Like until unless you are removing all kinds of pre-retinal adhesions or the traction, the folds cannot be loosened or it cannot be unfolded. And for this pre-retinal adhesion, I explained in my video that all the pre-retinal adhesion have to be removed along with the subretinal adhesions that is there with long-standing falciform folds that is involved in the macula. My purpose was not to settle the macula because a lot of other techniques are also available, like buckle and the previous thing, non-vitrectomy. But even the subretinal BSS injection was a, like one of few case series has been published in the previous year in last 10, 15 years
exactly.
that
Yes.
it's there. But nobody did the combined ILM peeling and this subretinal BSS injection to complete get rid of all kind of traction, whether it is pre-retinal or subretinal.
Besides SCVR, you have any ROP sequelae falciform?
No. I in my series it was no. It is congenital falciform fold, non-ROP cases, This video won the Red Buckler Award in last year.
Yes.
So the
And
thing to learn from Dr. Subhendu's videos is the excellent clarity in a full zoomed in frame also, and how he manages the settings of the camera. Excellent quality, sir.
And we have done this publication in retina, that is innovative technique combined ILM peeling and subretinal BSS injection in congenital falciform fold.
Thank you, Dr. Subhendu.
Thank you.
Fantastic presentation. Okay, so now against the order, we are going to go to Dr. Kasturi because she has got some commitment elsewhere. And I would request Dr. Kasturi Bhattacharjee to do a presentation on emerging digital technology for precise orbital surgery.
Emerging digital technology for precise orbital surgery at the microscale beyond current confines. This video has no financial disclosures or conflict of interest. Humans have always had an innate inquisitiveness towards exploring the unseen. They have also striven to develop an armamentarium to guide them through these untrodden paths. From the quaint era of compasses and binoculars to the current digital era of satellite tracking, the efforts into enhancing the navigation skills have been unceasing. The same was realized by surgeons, and they left no stone unturned in their attempt to incorporate the latest innovations in navigation technology to facilitate their surgical skill set. Digital technology and its application heralds the advent of the information age revolution for complex orbital surgery. Navigation guidance and three-dimensional printing have revamped the future of orbit and oculoplasty surgery to reach perfection beyond the current confines. In literature, the working of a navigation system has been compared to global positioning system, that is GPS, to simplify its understanding. Data is preloaded into the computer, which serves as location coordinates that relay the patient's anatomy and the surgeon's precise movements in relation to the patient onto the computer screens. Real-time updates such as intraoperative landmarks, position of the implant, etc. can be visualized to steer the surgery in the right direction. The software equips us with tools for differential color coding, precise marking, and mapping of the site of pathology with accuracy. One of the crucial applications of navigation guidance lies in the management of orbital fractures and midface polytrauma. Fractured orbital walls make for a treasure map where the surgeon has to meticulously look for the fracture lines and ensure that the reconstruction restores the normalcy of the patient's facial symmetry. The orbit plays a pivotal role in forming the vertical and horizontal buttresses of the face, which are the pillars to the foundation of the facial anatomy. Fractures in the orbital walls demand a scrupulous approach to achieve proper realignment of buttresses with customized orbital reconstruction. Manual segmentation is a time-consuming task, whereas auto-segmentation of the area of interest, followed by the use of mirroring feature, involves the superimposition of the contralateral normal orbital skeleton onto the disrupted site, which finds its use in unilateral disorders. The CT images are loaded twice, merging the mirrored orientation onto the original. This helps identify the exact measures of the defect and quantifies the displacement. Based on this preoperative planning, we can design a patient-specific implant to replace the defect and provide the required support to the fractured orbit. In this surgery, once the fractured bone is extracted, we can see that the intraoperative placement of the navigation probe enters the maxilla. Thereafter, we modify the implant based on the preoperative measurements and fix it using screws. The navigation can again be utilized to confirm the proper alignment. Such a structured management of orbital fractures yields excellent functional and cosmetic outcomes. Moving on to orbital apex and optic canal fractures. The intracanalicular part of the optic nerve lies in a tight bony canal which is about 10 mm in length. Here, it is most vulnerable to trauma. Indirect injury occurs due to transmitted shearing forces, while direct injury occurs from fracture of the canal or nerve sheath hematoma. Navigation guidance integrates an interoperative GPS system which enables the surgeon to identify bony and soft tissue landmarks in order to set the target and reach the destination. Preoperative requisite is of a high-resolution imaging in the DICOM format which is loaded onto the console. The user interface allows simultaneous viewing of axial, coronal, sagittal as well as 3D reconstruction of the CT. Transcaruncular incision is made to reach the posterior lacrimal crest. Further dissection along the medial wall is done to reach the anterior ethmoidal blood vessels which are cauterized. 12 mm posterior to these lie the posterior ethmoidal blood vessels which are retracted. 6 mm posterior to this lies the optic canal. Y-shaped annulus of Zinn is an important landmark of the optic nerve just prior to entering the optic canal. Using the Kerrison bone punch, the optic canal is decompressed and the optic nerve is deroofed as one can see in both the skull as well as interoperatively. This case also had an optic nerve sheath hematoma which was drained using a sickle knife. At the completion of the surgery, the navigation probe is inserted to confirm the endpoint of surgery. Navigation guidance provides real-time location, site of optimal surgical incision for minimal collateral damage, and marks the road to a successful surgical extraction of the orbital foreign body. Navigation technology finds its use in orbital apex tumors, where it can aid in accurate target localization with precise tumor margin delineation, along with careful avoidance of untoward vascular trauma at the time of resection. Three-dimensional printing technology has revolutionized the art of orbital reconstruction by enabling accurate preoperative virtual planning and creation of patient-specific implants that restore the orbital volume and its original anatomy to the closest possible facsimile. These three-dimensional reconstructed models reveal the exact location of the fractures and the amount of defect requiring correction, making the reconstruction extremely precise. It converts a 2D DICOM image into a 3D real-time image. This is an example of a grade 5 contracted socket whose preoperative three-dimensional reconstruction was done. This enabled us to compare the two orbits and measure the difference in orbital dimensions as well as volume. After thorough patient examination and socket measurements, he was taken up for surgery, wherein his inferior orbital rim was partially carved out, rotated anterosuperiorly to create the new orbital rim and was fixed with screws. This rotation consequently deepened the orbital socket. Thereafter, a temporalis muscle flap was raised and rotated onto the newly created socket and sutured. Surgical incisions were closed and an amniotic membrane graft was placed onto the surface. This extensive preoperative planning and judicious intraoperative manipulation of the orbital rim gave excellent outcomes which have been consistent even on long-term follow-ups. So, does the road to technological excellence end here? No. This heralds the advent of a new era where technology will pave way for an avant-garde approach on the landscape of orbital surgeries. The digital evolution is a work in progress which is headed straight for the stars. Thank you.
Amazing presentation, ma'am. And
Thank you,
just
sir.
like to, for the clarity of our viewers and even for us, was this software an exclusive one developed by you for this, or is it a generic available for orbital mapping or just skull mapping, I should say?
Yes, the software actually it comes with a neurosurgical unit,
Okay.
and then we have started using for the orbital apex, because what we have realized in situation like traumatic optic neuropathy, when these children come to us in a very productive age with loss of vision, we need to do something. And then the international optic nerve trauma study mentioned that nothing works, either high dose of steroid or surgery or anything else, or we observe. So then I had done lots of cataract dissection, how to reach this optic canal, because we know that ophthalmic artery is there, and just inferior lateral to the optic canal is your internal carotid artery. So any injury to that will lead to bleeding and the loss of life of the patient. So for that we wanted something to guide us. Like even if we reach the canal, we should be knowing where is the artery and where is the nerve. So then we have used, and we have asked, like we have told the company, like these are the things you should incorporate, so that we can have a MRA and a CT scan superimposition, which will guide us during the procedure to reach the optic canal. Following which we had done decompression with a minimally invasive technique, which I have shown you, just a transconjunctival approach. And we could regain vision from PL negative to PL vision coming back.
And regarding the imaging system, you used it intraoperatively?
Yes, it's a real time. It's a real time.
Okay.
So you use the navigation system for all your orbital reconstructions now?
So it's not for always, only complicated cases, like for fracture. Like nowadays we have patient-specific implant which are very costly. It comes to 2.5 to 5 lakhs. But we need something cheaper where we can customize and we can measure the volume. And this helps us to measure the volume so that every implant we can customize, and accordingly we can go for effective reconstruction.
And how expensive is the software?
The software, as you know, is a machine. Like
the real-time machine.
it will come in few lakhs.
I was curious. Wonderful work, Dr.
Thank
Kasturi.
you, sir.
You said that you could reconstruct one orbit by mirroring from the other orbit, right?
Yes, sir.
So if the both orbits are involved, then how do you reconstruct?
For that 3D printing, that's why the second digital innovation I have seen. When it's a one-side injury, then you mirror the normal over the abnormal, and then we know how much of volume expansion or inophthalmos we can measure it. But if there's a pan fracture, then we have to do a 3D printing. And many people ask me, why 3D printing? It is so costly. No, sir. To do a phaco surgery, we charge 20,000, but 3D printing comes to 12,000. So with the 3D printing, we can at least customize, we'll know where to put the implant and how do we go for effective reconstruction.
But 3D printing would be kind of extrapolation of whatever the anatomy is, because you don't have the normal CT scans or MRI for that particular patient.
Sir, same patient, CT scan, we have a DICOM format and we give it to them, then they do the 3D printing for us.
Thank you.
Yeah, excellent combination of surgical skills and technology.
Thank you,
Thank
sir.
you very much.
Thank you. So if you give me permission, can I leave?
Oh yes, yes, you have other commitments, you can. Okay, so now we go to the schedule to follow, and our first second presenter for today for judging is Dr. Kumar, and he will be speaking on tinkles for capsular wrinkles, demystifying zonular support. Over to you, Kumar.
Yeah, thank you. Can we start, please?
The zonules are a series of fine fibers that connect the crystalline lens to the ciliary body. The function of the zonules is to hold the lens in place. The zonular fibers arise from the pars plana and from the zonular plexus in the valleys of the ciliary processes and proceed to form the zonular fork, which forms the zonular limbs, anterior, equatorial and posterior, finally inserting into the lens capsule. The signs of panzonular weakness are well described in literature. The present video aims to demonstrate and discuss the signs of selective anterior zonular weakness, namely the capsular wrinkles, and selective posterior zonular weakness, namely the capsular flutter and the PC radial sign and their management.
Let's demystify the zonular weakness and sing some jingles for the capsular wrinkles. Let's demystify the zonular weakness and sing some jingles for the capsular wrinkles. What if only the anterior zonules are weak? Then my dear friends, you all may be left shell-shocked.
During capsular rhexis, notice the wrinkles of the anterior capsule beyond the rhexis margin. These take place because the anterior zonules are weak and there is no countertraction. A cohesive OVD may be used to prevent Rex's runoff. In such cases, one has to take care during cortical aspiration, and such bags may need an additional support with an endocapsular ring.
But if only the anterior zonules are weak, then my dear friends, you all may be left shell-shocked. When you perform the all-important capsular rexes, there is attraction, no counter-traction. The anterior capsule will show the wrinkles, and she will try hard to extend and just run off. If you're not careful, she will desert you, and to the equator she will quickly take off. What if the posterior zonular limb becomes lax? Then surely the PC will bulge forward and become slack. Once the cortex is out, you may see some fine lines. Please do remember this, all you PC radial sign.
During cortical aspiration, note the movement of the posterior capsule and its flowability with the cortex. As the cortex is stripped from the posterior capsule, there is neither any movement of the posterior capsule nor a flutter, thereby indicating strong posterior zonules. If the posterior zonules are weak, note how the posterior capsule follows the aspiration probe as the cortex is stripped off. Once the cortex is stripped off, note the fluttering of the lax posterior capsule indicating weak posterior zonular support. Yet another case of a posterior capsule flutter. Another case of selective weak posterior zonular apparatus. Note the fluttering of the posterior capsule upon the introduction of the IA cannula. When the cannula exits the eye, note the forward bulging of the lax posterior capsule along with the appearance of fine radial lines, which is the PC radial sign. These disappear as the capsular bag is inflated with an OVD. Here we postulate on removal of the irrigating cannula, the deflation of the capsular bag causing the posterior capsule to bulge forwards in areas where the posterior zonules are weak, while it is held back in place in the areas of intact posterior zonules, which gives rise to the radial folds or lines which we call the PC radial sign. We further postulate that such bags, when re-inflated with an OVD, the PC radial sign disappears. Such bags should always be strengthened by placing an endocapsular ring for better stability for premium IOLs.
If you encounter this, please do not fear. Gently inflate the bag with an OVD, dear. Stabilize the PC, dropping the anchor by placing in the bag a sturdy CTR. What if all the three zonular limbs become weak? Then surely the surgical scenario does become bleak. It's the right time to stay calm and not panic, because the lens is a sinking Titanic.
In cases of panzonular weakness, where there is a subluxation present, one can perform a femto-assisted rexis with a fragmentation of the lens. The capsular hooks will support the subluxated area till the fornix of the lens. This is followed by safe phacoemulsification in the bag, followed by the placement of the endocapsular ring in the bag. In cases where the subluxation is more than 6 clock hours after phacoemulsification, a Sione's ring can be used to secure the capsular bag to the sclera, followed by IOL implantation in the bag.
Deploy the capsular hooks, engage the Siones. These are the lifeboats which are worth every penny. Try best to salvage an intact capsule bag so that an IOL can be glided in the bag.
To summarize, the presence of capsular wrinkles while performing capsular rexes is a sign of selective anterior zonular weakness. Use of a cohesive viscoelastic prevents the rex's runoff in such cases. The novel PC radial sign and the floppiness of the posterior capsule, causing it to follow the aspiration probe during cortex removal, are signs of selective posterior zonular weakness. This floppy posterior capsule should always be stabilized with an endocapsular ring. Iridophacodonnesis, a crescent sign, and irregular anterior chamber depth are signs of panzonular weakness. Capsular hooks, Sionis, and Emmert segment should be used to perform a safe in-the-bag phacoemulsification followed by an IOL implantation in such cases. Thank you for your attention.
Thank you.
Excellent presentation and fantastic animations, Pratham.
Did you compose and sing the song yourself?
No. Yeah, no, the lyrics is written by Dr. Bhavin and singing is done by a Christian guy, very good singer. We got music specially directed separately and we piled up everything together.
Regarding the management strategies for anterior as well as posterior zonular weakness, do you think there is any change in the way you manage? Both the situations you would still use a CTR.
Yes.
That wouldn't change much.
Yeah.
But according to you feel that the chances of rexes running off are slightly high if you have an anterior zonular weakness when you see the capsular folds.
Yes.
That was the message you wanted to convey.
Because if we get these wrinkles, we know that the anterior complex is not very strong. So even once we do the phaco, it's better to give support to that bag for the long run. And this PC radial sign, which all of you might see, but I don't think it's ever documented because we have not. So then I went ahead and did a Miyake's and understood the posterior. We all know posterior zonules are there, but to separate each one and present that was the idea of the whole video.
How would a generalized combination of both anterior and posterior zonular weakness, what would the science would view?
So same thing, if it is anterior, you will get these wrinkles. If it is posterior, you get a PC.
So you'll get all the signs if there's there.
And you will also get, when we irrigating the floppiness of the posterior capsule, which will be a sign of posterior capsular weakness.
And we see the fluid misdirection happening, and during caustic, the posterior capsule will coming up.
Yeah.
So this Miyake, how did you record it?
I went to Dr. Abhay. So he has this thing, so we cut the eye and then photographed it from the back. So you remove the iris, you remove the rest to get the front view, and then you cut the eye from the middle. So I had taken eyeballs with me from Mumbai, which were not going to be used. The cornea was not useful. So I thought, and then I started putting triamcinolone on to train, because how to see the zonules. So it's difficult to see the zonules, so I put some triamcinolone on. So then the triamcinolone went and got stuck to the zonules, which even we didn't know, but we just found out. So we tried different things and then we could see the zonules.
Excellent and very novel way to visualize.
Thank you.
Thank you, Kumar, for a fantastic video.
Thank you so much.
Dr. Devashish Datta.
Yeah, Dr. Dabashish is going to present on a panacea for double dialysis. Good afternoon, everybody. What happened?
As ill luck would have it, I suffered a blunt trauma to my eye and now I can't see.
Dear brother, the blow has resulted in 3 clock hours of iridodialysis in tandem with zonular dialysis with subluxation and thereafter significant cataract.
Please help me, doctor.
Your case is rather unique, and the literature does not help much regarding its management. But don't worry, I have a new idea to fix both the dialysis at one go. Let me explain to you what I plan to do.
Okay, doctor, I am all ears.
A Hoffman pocket is fashioned adjoining the area of dialysis. The Gore-Tex suture is passed across the bed of the Hoffman pocket so as to enter the eye at the ciliary sulcus. It is then carefully negotiated through the peripheral torn iris from outside inwards and brought out of the eye by railroad through the pupil. The needle is passed through the eye of a segment CTR and guided out of the eye by railroad technique by passing through the peripheral iris and then through the bed of Hoffman's pocket from inside out. The segment CTR reinforces the equator of the subluxated capsular bag, and the dialyzed iris is approximated to its root by titrating the pull of the loop of the suture. Thus, a hangback repair is done for both the dialysis by a single loop of suture. Here we go. Mm from the limbus is marked and a scleral tunnel is made with limbal entry. I prefer to use triamcinolone right at the beginning to stain the prolapsed vitreous. Small aliquot of trypan blue is used to stain the anterior capsule lest it escapes into the posterior segment.
Oh doctor, I can't see the light.
All is well, don't worry. The area of dialysis is plugged with cohesive viscoelastic. There are folds in the anterior capsule and rhexis is completed with utmost care. Two stab incisions are made adjoining the area of dialysis, and capsular hooks are used to support the area of dialysis temporarily. .23 gauge trocar is placed in the pars plana.
Oh doctor, it hurts.
Relax, it won't hurt anymore. Pars plana anterior vitrectomy is done with the cutting port mostly facing the optic disc, lest it injures the still intact posterior capsule. Irrigation is maintained in the anterior chamber. This keeps further vitreous prolapse at bay. Controlled hydrodissection and careful bimanual rotation of the nucleus is attempted. Vitreous already in the anterior chamber is removed. Nucleus is divided by direct chop and some fragments are emulsified. Now that some nuclear mass has been removed and the bag is unstable, CTR is injected to reinforce the capsular bag.
How are we doing, doctor?
It's all okay. We are going fine. Now we are going to use the Gore-Tex suture as you are pretty young. I have explained to you that it is off-label.
That's okay, doctor.
We enter the eye at the sulcus through the bed of scleral pocket at the junction of 1/3 and 2/3 of the area of dialysis, passing through the outer edge of the dialyzed iris and brought out of the eye through the pupil by railroad technique. The eye of a segment CTR is threaded by the Gore-Tex suture. A similar sequence is attempted by a 26 gauge needle. The needle is docked and brought out through the bed of the scleral pocket. The segment CTR is now negotiated into the equator of the capsular bag at the area of the dialysis. Oh no, the returning suture has passed over the iris.
Oh doctor, what's the problem?
Just relax. Don't worry, it will soon be all okay. The returning suture is released and removed. This time I will do it right. A 26 gauge needle is bent into a bow, passed through the bed of scleral pocket and then through the peripheral iris and brought out at the incision through the pupil. The free end of the Gore-Tex suture, which has been eyed through the segment CTR, is threaded into the lumen of this needle and punched with a needle holder so as to keep it in place as the needle is withdrawn out through the sclera. The segment is properly aligned within the capsular bag. The combination of the segment CTR, the regular CTR, the capsular bag, and the dialyzed iris is drawn to the periphery and fixed to the sclera by titrating the knot.
What about the IOL?
Oh yes dear, a multi-piece non-aspheric IOL is placed in the bag. The multi-piece IOL is preferred as we can salvage the situation by resorting to scleral fixated IOL if needed. The Gore-Tex knot is buried inside the scleral pocket. Conjunctiva is opposed. You're doing fine. You can see 6'9" with 0.75 diopter cylinder.
Thanks, doctor.
You're welcome. This novel technique helps to kill both the dialysis at one go.
Thank you very much.
I'm not getting it.
I'm using... No desk job for me. Thanks a million, Doc. You are most welcome.
Wonderful demonstration of your skill, sir. I think the pressing of the with a needle holder, the 26 number needle, to ensure that the Gore-Tex gets squeezed in between. That was an excellent tip.
That was impromptu.
So this Gore-Tex switches, from where did you acquire?
I got it from a friend in US. It is off-label. You don't get it there. Even there you cannot buy. Somebody there who's doing cardiothoracic can only give it to you. So it was a difficult get.
Yeah. So can you use any other suture material for this? Why Gore-Tex?
Gore-Tex is it won't degrade so fast. Even Tenno nylon, or you can use after 8 or 10 years, or even 20 years down the line, it might break. It becomes friable. But this is supposedly it should not go, and it will stay like that. And there's another beauty of this thing that I'm not use the needle. Whatever needle we use, the needle creates a wider bore than the suture. And here, the needle bore and the bore of the suture itself are the same. So when you pass through, there's not much of a redundant space in between the tissue.
It would be as inert as nylon inside the eye.
Pardon?
It will be inert inside the eye as you have nylon or the other suture.
Yes, it's insert. It is off-level, but it is used in human tissue. It's just like silicone, suppose. It's inside the eye. It's used in cardiovascular surgeries. I don't know all that details, but and the size is this is the thinnest possible available. They have some VT and SR7, 8 or something. It's not like the 10 0, 8 0 like that. And they don't give it to ophthalmic people somehow.
I've seen few videos where they have used the Gore-Tex suture to fix the aqueous IOL on scleral fixated way.
It can. For long term, but some people are reporting cheese wearing of it, but it stays for a long time. That's why in a young patient having a long lifespan, long way to go, it's better to go for this sort of things.
Yeah, they are from US.
Excellent, Dr. Devashish. There were a quite significant number of pigments over the IOL optic in the poster picture you showed. Any reason you can make out why there were so many
The
pigments?
iris was handled, and at the posterior pigment epithelium, something.
And there was no vitreous encoded in the AC.
No, I will check it with the tricot,
yeah.
and I saw that I have done pars plana as much as I can with the infusion in the anterior chamber, so that the vitreous does not come from an anterior chamber.
Thank you very much, doctor.
Thank you.
Thanks a lot for excellent video. Okay, so
presenters, please be seated in the first row.
Yeah, Dr. Patwardhan, you are next, and you're going to present on understanding the unseen universe of
I repeat,
zonules.
presenters, be present in the first row.
की नहीं आवाज बढ़ा
hidden behind hidden behind the
Can we have the lights dimmed, please?
anti-iris is the unseen universe of zonules. Zonules which give stability to the human lens. Though the frank, unstable zonules can be observed preoperatively in the form of subluxated lenses phacodonesis or can be also observed with UBM, but still the subtle zonulopathies can be seen only when you start the surgery. So in this video, we would like to demonstrate two types of subtle zonulopathy which can be picked up during surgery. The basic anatomy of the zonular complex shows that there is anterior, equatorial and posterior zonular limb. In diffuse zonulopathy, there is phacodonesis and subluxation, but in case of posterior zonulopathy, where the weakness or laxity is limited to posterior zonules, it may not be evident preoperatively. Same is true with anterior zonulopathy, where only the anterior limb of the zonules has laxity or weakness. In a case with normal zonules, what you can observe is that during capsulorhexis, there is no movement of the lens, no folding of the capsule, stable anterior capsular rim, and the bag held by zonules gives good counter traction during cortex removal. Now let's see the first case where anterior zonulopathy can be experienced. During capsulorhexis, you can see there is no frank folding of the anterior capsule, no lens movement, indicating that there is no severe frank zonular weakness. As we proceed into the surgery, we observe that the anterior capsular rim is unusually unstable and you can see the movement or fluttering of the anterior capsular rim here. When you notice this, there is definitely laxity or weakness of the anterior zonules, and there is always high risk that anterior capsule may be pulled during cortex aspiration. So you have to be extra careful here. Make sure you are holding the cortex and not the capsule. Use slow cortex peeling technique, and in case of severe movement of the anterior capsular rim, you can use CTR. In this case, the unstable anterior capsular rim indicates that there is laxity of the anterior zonular complex, but as there is no movement of the peripheral posterior capsule or equator of the bag, it indicates that the posterior zonules are still strong and giving good counter traction during the cortex aspiration. It is best to stabilize such bag with capsular tension ring for the long-term stability of the IOL bag complex. So after seeing this case, we'll compare it with another case, which is a case of posterior zonulopathy. To begin with, you can see the capsulorhexis appears to be going on well. No significant lens movement again, indicating no diffuse zonulopathy. Some amount of folding of the anterior capsule, but again not very severe, and there is no frank zonular weakness in this case as well. But as we move on to phaco and cortex aspiration, we notice that when we try to remove the cortex, there is posterior capsule being pulled in along with the cortex, indicating that it is not supported by the posterior zonular complex. At the same time, the anterior capsular rim appears stable and there is no movement of the anterior capsule rim. Stable anterior capsule rim indicates that zonular weakness or laxity is restricted to the posterior zonular limb here. Now we move on to the area of normal posterior zonules. You can see that the posterior zonules provide good counter traction for the cortex removal with no movement of posterior capsule in the area where the posterior zonules are strong. In the area where the posterior zonules are weak, always be careful, as if you pull quickly it can cause frank zonular dialysis or can result in peripheral posterior capsular tear. So observe that only the cortex is occluding the tip and use the cortex peel technique, where you gradually try to release the cortex from the posterior capsule. Little bit of tangential movements and very slow movement of the probe is recommended. If the instability is more, one can insert capsular tension ring and then proceed with the cortex removal. All throughout, what you can observe is that the anterior capsular rim is very stable, indicating that the anterior zonular complex is strong, but the posterior zonular weakness or laxity is present. So this is a case of posterior zonulopathy. Patience is required in such cases to avoid any complication. So intraoperatively it is important to recognize this sign and take necessary precautions. Again, just demonstrating that the anterior capsular rim does not move, so the zonular weakness is restricted to posterior zonules. You can also release the cortex carefully by holding the posterior part of the cortex and release it slowly from the posterior capsule. And it is recommended to put capsular tension ring for long-term stability of the IL back complex. So with this video, we would like to demonstrate the two types of zonulopathies, anterior zonulopathy and posterior zonulopathy. And hopefully we'll understand better about the unseen universe of zonules.
Well, it's a coincidence. We have two videos today on zonules itself, and I'm sure those both of you have not communicated with each other, but that's a coincidence. Saurabh, I think your demonstration of the posterior zonular weakness in slow motion was exemplary. I think it's very wonderfully demonstrated. Whenever there is an issue here as well, in eyes where we don't have healthy zonules, the hydrodissection will not happen perfectly well, just because we don't have a counter traction. And that's the reason also that the cortex aspiration becomes a wee bit difficult. So all of them are contributing. I would say that your demonstration of how you should remove the cortex was excellent. Maybe I would not hesitate to use a CTR a little bit earlier itself. The first sign I see it, I would just go ahead and do it. And of course, using a tangential way of stripping the cortex would work well, even with the CTR on. Overall, I think an excellent demonstration of both the anterior and the posterior zonal weakness.
Yeah, I think the purpose of video was to show the subtle signs which are missed. As experience goes, we can pick these signs early. Otherwise, what happens? We miss these signs and we end up with complete zonular dialysis, and then we feel it was pre-existing or it was iatrogenic, but it may be the subtle zonulopathy, which if we can pick up early, we can be more careful and avoid the subsequent consequences.
Excellent. Just a little question, small question. Are there any
in the presence of both
are there any specific clinical entities or associated with the anterior or posterior zonulopathy?
Yeah, so I found it in few cases. I didn't find any, because in frank zonulopathy we generally pick it up during capsulorhexis, but these are two entities which we cannot pick up during anterior capsulorhexis, and we
come to know once nucleus is removed. So probably nucleus is, filling the bag is hiding these zonulopathies.
My intention was to know if it's associated with like PEX or high myopia or some other degenerative
Both
condition.
these cases were normal axial length and normal anatomy.
So you are putting an endocapsular ring in all subtle zonulopathy also?
Yeah, so actually
there is no need, or you think that you can...
So we don't know whether it is the zonules are broken or they are just more lax, because we don't actually have a dialysis in such cases. So we don't know. So that's why, to be on safer side, we put the CTR for the better centration later.
Okay. Thank you, Dr.
Thank you.
Patwardhan. Fantastic video. Thanks a lot. So we move on to the next presentation, the antimicrobial lake. Dr. Lionel Raj. Yes, sir. Can you please present it?
Good morning, everyone. Dear chairpersons and dear friends, I do not have any financial interest in the following video, VT26.
The producers have no
Can you dim the lights, please?
The producers have no financial interest in the product matter shown in this film. Up to 5% of all blindness are due to ocular infections. The global estimates of microbial keratitis, the cause of unilateral blindness, ranges 1.5 to 2 million cases a year, and 58,000 registered emergencies in the US. In our part of the world, 113 of a lakh population have become blind monocularly following microbial keratitis. Presently, the treatment is primarily topical dosage forms as eye drops and eye ointments. However, precorneal factors and anatomical barriers affect their contact time with the lesion negatively. Introducing a novel concept of drug repository contact lens system, the antimicrobial lake. The drug repository contact lens is a therapeutic soft contact lens for continuous wear up to 1 to 2 weeks, made of aquaphilicon A and water in a buffered saline solution. This consists of a unique design of dual base curve as to result in a central reservoir for drugs and fenestration holes to enable capture of applied topical antibiotics. It's a novel technology aimed towards prolonging drug corneal contact time for effective healing and reduced frequency of application of eye drops. We conducted a randomized controlled clinical trial to test this hypothesis, comparing topical antibiotic alone and topical antibiotic with repository contact lens in cases with bacterial keratitis. By measuring ulcer and infiltration sizes using bacterial keratitis score, pain analog scale, improvement in vision, corneal haze, anterior chamber reaction by 12 hours, day 1, day 3, day 5 and day 14. Case category 1 included bacterial keratitis less than 4 mm in maximum dimension and were subjected to repository contact lens with topical antibiotic monotherapy of moxifloxacin, second hourly for 3 days and 6 times a day till recovery. The average resolution of infiltration by 12 hours was 0.66 mm, by day 1 was 1.27 mm and day 3 was 2.06 mm, which was significantly better in the first 3 days in the repository contact lens group. Hence, we recommend the treating physician to decide whether or to continue the contact lens after 3 days based on the clinical signs. Bacterial keratitis healed within 5 days with contact lens system and after 5 to 7 days when antibiotic alone was used. A mean of 1.5 lines improvement in vision was noted by day 1, which improved by another line by day 3 in the repository contact lens group against only drug group. The pain reduced in the scale by 2.7 points at 12 hours, by 5.29 points at day 1 and 6.86 points by day 3, which was significantly better than being treated with drops alone. There was a significant reduction of corneal haze and reactions in both the groups, more so with the contact lens group in the first 3 days. Category 2 cases were bacterial keratitis larger than 4 mm in their maximum dimension, treated with a monotherapy of moxifloxacin in gram-positive group of organisms and with amikacin in gram-negative group. The effective healing by means of improvement in bacterial keratitis scores and the reduction in pain scale of larger ulcers started by 1 to 3 days, and the ulcers were completely resolved before 2 weeks in patients treated with repository drug contact lens group. We aimed in retaining the drug in the precorneal space like an antimicrobial lake using a specialized dual base curve lens system rather than the attempts of sustained release properties tested using regular therapeutic contact lenses soaked into antibiotic solution before its application. Also, the fenestrations in the lens enabled further capture of medications whenever applied. Triamcinolone, used as a staining agent in the presented vitreous during surgeries without staining the lens, was used as a testing agent in the drug retention studies. The drug availability in the central reservoir peaked immediately and were detected in the potential precorneal space up to a maximum period of 4 hours, favoring extended drug corneal contact time, tested both by OCT and clinical photography. Occasionally, mucus strands were found in the precorneal space, clogging the fenestration holes. We recommend that it could be washed with BSS, or the lens may be removed, washed with BSS and reapplied. To conclude, from our randomized control studies, the drug repository contact lens system promote effective healing and early pain relief in the treatment of bacterial keratitis. This novel concept is effective in prolonging antimicrobial availability in the precorneal space over the site of the lesion, which could affect the overall outcomes in bacterial keratitis. Employing a drug repository contact lens may reduce antibiotic regimen and the burden on the medical staff, and also could improve patient tolerance and may change the present practice patterns.
Thank you for watching. So before we put this, we have to be very sure that it is bacterial, so we have to confirm it by
The
scraping and
use
everything.
of
This randomized control studies, and since we have microbiology laboratory within, we do a therapeutic diagnostic scraping immediately after clinical judgment. We look for the gram staining pattern, and only cases with BK were included in this study.
Okay.
We wanted to be very clear. And however, we would get the antibiogram reports by 48 or 72 hours based on the clinical response, and based on antibiogram report, physician can have a judgment of changing antibiotics if at all.
I think I was basically coming to that, because if you put a contact lens and your antibiotic is not, organism not sensitive to antibiotic, that particular antibiotic, then there's a little potential for harm rather than benefit.
No, generally as per the Cornea Society guidelines, we treat either with a monotherapy of quinolones. Anyway, even if we don't treat with the repository contact lens, we have to go with a empirical treatment, either with the monotherapy of quinolones or with a combination of cephalosporin and aminoglycoside. So the same pattern.
Yeah,
is
my
being
intention was that if you are using antibiotic which is not effective, but you have put contact lens on top of it, so that situation might, cause stagnation of the infective secretions and actually harm the cornea.
It didn't. That's why this is a randomized study with 40 cases which was randomized in 1:1 ratio. It didn't in cases of BK. And moreover, the rationale behind doing this trial is that there is an unmet need always for infectious keratitis, especially in tropical countries like ours. Number two is the loading dose concept. Even by the American Academy of Ophthalmology, it is 5 to 15 minutes. Every 5 to 15 minutes, someone has to load for hours and then hourly till we see a resolution. So could we reduce the burden? That was the research question. Second, the precorneal factors like tear film, which keeps washing away the antimicrobial from the site of the lesion, could we retain? So these two are the...
Did all your patients have the fenestrated contact lenses, or you initially tried with the regular ones?
No.
You began with the fenestrated contact lenses itself.
Not alone fenestration, it also has a dual base curve as to make a central lake.
Okay.
So it is specially designed.
Designed for it. And the antibiotics which you used add-on, were they the same?
No, in this particular series we used only a monotherapy with quinolone.
Okay. And how about its for fungal keratitis? Because in India, the fungal keratitis incidence is definitely much more compared to pure bacterial ones.
All right. See, away from this topic, because this antimicrobial lake, this particular video is pertaining to BK, bacterial keratitis. So do we have experiences on fungus? Yes, we did, with varied responses. There are few challenges with fungal keratitis. First of all, fungus we need to do a therapeutic scraping very often. So we can't measure. Secondly, the major drug which is being used for fungal keratitis is natamycin, which is a polyene, large chain. And we are also working with retaining a polyene and getting polyenes through fenestrations. That will be a challenge. Unlike voriconazole, polyenes would be a challenge. Natamycin would be a challenge. So that is number two. So we had few cases. Some of them healed well with voriconazole. Some didn't. But we are also working on some additional efficacy data for fungal keratitis. Before that, I cannot be in a position to guide.
In your series of cases, in your study, did you see any things which didn't work, and could you analyze why they didn't work in any of the eyes?
Out of this series, 3 and 2 cases of group 1 and group 2, that is cases and control. No, control and cases, 3 and 2, were excluded for analysis because of improper reporting in time and because of discontinuation of lens in between. But none of them required additional therapy like superficial keratectomy or proceeding for therapeutic grafts. None of them did have any such reactions, adverse reactions.
Thank you, doctor.
What about the infiltrates that are at the limbus? So does this take care of that also?
See, this is again aimed towards BK, microbial keratitis. Most often infiltration at the limbus, they are immunological in their pathogenesis. Not necessary. It can even be infective. Yes, because it is a 14 millimeter diameter lens with nearly 9.5 millimeters of central lake. So I guess even we can try with steroids in immunologic keratitis, PUKs.
Last question. Do you think that, as in the AIOC2022, it was almost touching the cornea? If you can make the vaulting a little steep, so it will go to the limbus and have a more amount of lake,
yes,
as you call it.
Now, we did find out using this is from help from one of the Israeli companies. We did find out with fluorescein, not the one which stains the lens, but it is they call it high density fluorescein, which doesn't stain we found 60 to 80 microns lake. But of course, yes, for candidates like fungus, it need to be more. It need to be more. Thank you, sir.
Thank you, Dr. Lionel. So on to the next one for this session, and that is Dr. Purendra Bhasin, sir. And the topic is ultimately what matters is timing and approach in ocular trauma, a New Year Eve trauma story.
We here present our video. Ultimately, what matters is timing and approach in ocular trauma. This is a New Year Eve trauma story. We have no financial interest. On the day of New Year Eve, due to excitement and hurry, while returning from office on his motorbike, this patient met with a road traffic accident. 26-year-old male presented with open globe injury. He had a full thickness tri-radiate corneal tear with uveal tissue prolapse. Projection of rays was accurate and there was no reverse relative afferent pupillary defect. The CT scan of brain and orbit was noted to be normal. The patient was taken for an emergency corneal tear repair with automated anterior vitrectomy. Intraoperatively, the lens was found to be spontaneously excluded. On the 7th post-operative day, the patient has BCVA of 6/24 with well-opposed corneal wound and near total loss of iris tissue. The intraocular pressure and fundus were noted to be normal. Over the course of 10 months, the cornea and retinal status remained stable. However, the patient developed refractory glaucoma. Because of two main concerns, refractory glaucoma and a visual rehabilitation due to loss of crystalline lens and the iris tissue, the patient was planned for a combined Ahmed glaucoma valve and an aniridia intraocular lens. This shows conjunctival dissection for Ahmed valve. The valve was planned to be placed 8 mm behind the limbus. This shows the priming of Ahmed valve. The valve was placed in superotemporal quadrant. The tube was cut to an approximate size and was tucked under the conjunctiva. An aniridia intraocular lens was planned via superior tunnel of 9.5 mm. Due to the paucity of the surgical space, we modified our surgical technique to a single inferior scleral pocket. Superior IOL haptic was tied to the section itself with a 9-0 Prolene suture. We used the anterior chamber maintainer. No viscoelastic was used. We used limited anterior vitrectomy and the stump of the iris was also removed. Prolene suture is pulled out of anterior chamber and cut. The two cut ends are fixed to the eyelets of the IOL haptic. The aniridia IOL is bulky and has an optic size of 9.5 mm with a central visual optic of 5.95 mm. The lens is now placed inside. The section was closed with 10-0 nylon suture. The Prolene sutures were secured to the scleral pocket. The Ahmed glaucoma valve tube was released. The valve was reprimed and the tube was placed in the anterior chamber. The corneal patch graft was used to cover the tube and was secured by 8-0 nylon suture. At the end, the conjunctiva was closed by 8-0 vitral suture and the anterior chambers was reformed. Early post-operatively, he maintained a visual acuity of 6/24 with 14 mm Hg intraocular pressure. At 1 year follow-up, there was well-functioning wall with a deep anterior chamber, centered aniridia intraocular lens, intraocular pressure of 14 mm Hg, and he maintained a vision of 6/24. 2 years later, he developed corneal decompensation. Vision dropped to 6/60. So we planned optical penetrating keratoplasty with trimming of AGV tube. 8 mm of recipient cornea is trephined using Baron vacuum trephine. OVD is injected and AGV tube is trimmed to prevent it from touching the donor cornea. .5 mm donor cornea is secured using 10-0 nylon interrupted suture. OVD is washed and AC is reformed. BCL is applied. 2 years post-operatively, he maintained a vision of 6/9. To conclude, always have a plan before treating a patient with complex ocular trauma. Any intervention should be dictated by what is best for the eye, not what is possible by the attending ophthalmologist. Wait till the appropriate time of intervention. Be ready for intraoperative surprises. Anticipate problems that may occur and have a backup plan. Thank you.
Excellently managed case and well documented.
Thank you.
Very good presentation, doctor.
Thank you. Thank you.
Very well done. In fact, such kind of severe penetrating trauma, usually, you see ocular hypotony, ciliary body atrophy. But 2 years down the line, you're lucky you have.
2015, he had the first injury.
2015.
15
so
December,
now, okay.
31st December 2015.
Right.
That night itself, he operated upon around 8 or 9 o'clock. And the primary repose was done in 2015. Then 2016 we did the first surgery, second surgery, and in that we did an iridia IUL and AGV simultaneously. And then 2 years before, 2.5 years back now, we did a keratoplasty and 6.
Your amazing perseverance, you didn't let go of him, and God was kind that his retina was spared. Every other part was affected, his retina was spared, and that's the reason. I think excellent. Congratulations on your perseverance, and patient is lucky to have you.
Thank you. Thank you. Actually, message is that only, to have patience and perseverance in ocular trauma and do whatever is required when the stage comes. That is what is the message. Thank you.
Thank you.
Okay, the next presentation is Mixing Complex DSEC and SFI oil. Chief and presenting author Dr. Karan Bhatia. beginning.
Mixing complex DSEC and SFIR. So a complex or a challenging DSEC could be the result of an intraoperative complication or due to the challenging situation of the eye itself. Sclera-fixated IOLs are the most popular approach for the management of aphakia. Various techniques have been described for it, however they are challenged for the anterior segment surgeons. So we described the mixed technique, which is a modified adaptation of the Yamane and the Exnick techniques, where the externalized haptic is cauterized to form a flange like the Yamane technique, and the needle is brought out of the sclerocorneal tunnel and the proline haptic of a 3-piece IOL is introduced externally like the Exnick technique. Therefore, M stands for modified adaptation, Y for the Yamane and X for the Exnick technique. So we recently published this in the Indian Journal of Ophthalmology. Seeing the very promising results of about 65 eyes, we thought, can we combine them? So the case details are a 23-year-old gentleman, one eye, status post-trabeculectomy, the vision being PL present and PR accurate, and he was dependent on others for the simplest of daily tasks. If you look at the picture, there is a thick fibrotic Descemet's membrane or retrocorneal membrane and 360 degrees of central and peripheral anterior synechiae. The question arose, what to do over here? Should you do a full thickness keratoplasty or would an endothelial keratoplasty do justice? So this was the case. So the step 1 is the decision making. For this, the epithelium is removed for a better visualization of the eye structures. Step 2 was anterior chamber reconstruction. Here, using a reverse Sensky hook, the retrocorneal membrane or the Descemet's membrane complex was separated from the undersurface of the corneal stroma. Anterior synechiolisis was done using iris repositor. You can see using this repositor only, the retrocorneal membrane was stripped. One has to be very patient over here as you can see the anterior adhesions of the iris. Membranectomy was done then using a micro scissors from various ports that were made. It is sometimes very difficult to peel these completely, so therefore cutting with the scissors really helps. This membrane or the DM complex was then removed. You can see how thick it is. After this, you can see the visualization of the anterior chamber better, and you can see peripheral anterior synechiae that were there. There were multiple iris tags. They need to be cut with a vitrectomy cutter, otherwise they will create problems for the survival of the graft. The next step was the sclera-fixated IOL implantation. A clear corneal incision was made which was enlarged to about 5.2. An AC maintainer was put and approximately 2 millimeters away from the limbus, an angled transconjunctival sclerotomy was done using a 26 gauge needle, and this needle was brought out of the corneal incision that was made. The leading proline haptic was inserted in the needle lumen, and this IOL optic complex was directed into the anterior chamber. The needle haptic complex was brought out of the sclerotomy site. The PVC stopper was applied to prevent slippage of the haptic, and similarly 2 mm away on the other side, the needle was taken into the eye and then brought out of the corneal incision, and the trailing proline haptic was then introduced into its lumen. This needle haptic complex was again brought out of the sclerotomy site. The next step was the titration, and you can see that the IOL was very well centered. So the haptic was then trimmed to about 1 millimeters or slightly more, and a flange was created using a low-cost heat cautery, and this flange was buried intrasclerally. The PVC stopper on the other side was removed. Again the haptic was trimmed and a flange was created using the heat cautery. This was also buried intrasclerally. You can see the IOL was very well centered. Now the next step was the Descemet stripping endothelial keratoplasty. You can see over here that the 7.5 mm punch was made, but the interface was attached, which was cut with the scissors. The graft was very thin and it folded. This graft was unfolded, and using the needle insertion technique, ultra thin desec graft was put inside the eye. The graft was unfolded using tapping movements in a shallow anterior chamber, and the air was injected behind the endolenticle to oppose it to the undersurface of the corneal stroma. The various ports were sutured. So post-operatively, this patient did extremely well, and on day 21, you can see the cornea started becoming clearer, the IOL was very stable, the graft size was about 55 microns, and the patient had an uncorrected visual acuity of 6/36. On day 67, this patient improved his vision to about 636, which is improving with glasses to about 618+2. You can also see the flanges on this side of the screen that they were nicely intrasclerally buried, and the IOL was very well stable and the graft was becoming clearer. The best part about this was this patient became independent and was running inside the OPD. It really made a difference to change his life for the better.
Thank you.
It's sorry.
Please go ahead, doctor. Please.
So it's a beautifully managed case. Considering the one-eyed and age of the patients, what you did for him is amazing. But how is it different from the regular Yamane technique, except for the silicon sleeves?
Okay. So this is basically, there are two techniques. M stands for modified adaptation, Y for the Yamane, and X for the XNet. Yamane is the creation of the flange. XNet was made by Dr. Prabhu. So the thing is, when you introduce the haptic outside the eye, it is much easier to deal with it inside the needle lumen than inside the eye. So what I have done is I have basically combined those two. So the needle is inserted outside the eye in the haptic inside the needle lumen, and the flange is created. But you need to cut the haptics also. I've used Orolab 3-piece lenses. You need to cut it, otherwise these flanges they come out externally. So you need to have a taut haptic there, so that first of all it prevents pseudophacodonosis. It's stable as well. And you can actually with this technique do an SF IL, just the IL part, in about 10-15 minutes using an ACM.
And the second thing is, why didn't you use an anti-radial lens, since there is no iris?
Not available. It wasn't available with us.
Okay. What happened to the other eye, basically?
Other eye, I don't remember. I forgot now, but
thank you.
I think this, what was the original pathology? He had a fibrous ingrowth.
Yes, no, this is a retrocorneal membrane. He had a trap before. So the situation was there's a very fibrotic membrane.
There was on the iris also.
Yes,
it was growing on the iris as well. Yeah.
You see the pre-op picture.
So it's more like a fibrous ingrowth, isn't it?
Yes, it was a
so
fibrous.
I'm just thinking. I mean, your follow-up is very short, only 67, 8. What happened after 1 year or 2 years?
He's doing well. He's doing extremely well.
Did it reoccur because the fibrous
No, not at
growth
all.
can come back again?
I have done a DSEC there, sir. So it did not come back. So with an endothelial keratoplasty, he's doing really well. It didn't come back.
You mentioned trap was done earlier, is it? What happened to that part?
It failed. The trap failed.
And the pressures are now still
he's on
under control after all interventions?
Yeah, he's on 2 AGMs along with this, but he's doing well.
What helped your decision? Like, you opted to dissect. What was the turning point for decision making?
The visualization.
Like you did an anti-segment OCT helped you, or what?
Sir,
Like you thought that dissect would help you?
What happened was when I did an anterior segment OCT. But I thought I'll go decide inside. That's why when I was able to strip that part. Then I realized if I was not able to do that, I would have done a PK.
Yeah, I think intraoperative decision making.
Yes,
was,
yes,
okay.
yes.
Amazing work, Dr. Karan. Keep it up.
Thank you, sir.
Yeah. Thank you. Nice adventurous surgery.
Yeah.
Okay, so our next speaker will be Dr. Rakesh Shakya, and he's going to speak to us about combined phaco and PCIOL implantation with modified NPDS.
We all know glaucoma and cataract both are the disease of old age. Many patients usually present to us with visually significant cataract and advanced glaucomatous optic neuropathy. The surgeon not only aim to provide adequate IOP control but also provide good visual recovery as per the patient expectation. In the presence of both advanced glaucoma and cataract, there is an option performing cataract surgery combined with penetrating or non-penetrating glaucoma surgery. Trabeculectomy, which has been the gold standard glaucoma surgery till now, but penetrating nature of the trabeculectomy make it prone to several complications, many of which are sight-threatening. In the literature, various attempts have been made to preserve the scleral space under the superficial scleral flap, like collagen implant, reticulated hyaluronic acid implant, and viscoelastic implant. So I start in the onyx base flap about 6 to 7 mm. Bleeders are then cauterized with bipolar plate filled cautery. Marking is done with a caliper 5x4 or 4 partial thickness scleral incision with 50 number blade. So technically a rectangle 5x4 mm superficial scleral flap is fashioned using crescent blade and dissected forward until the corneal periphery reached. This raised flap is dissected 1 mm into clear cornea. The flap is hinged. A smaller, deeper second scleral flap is outlined and dissects forward until the Slem's canal reached. Then I shifted temporarily to clear corneal phacoemulsification, so AC entered with the 2.8 keratome. After staining of the anti-lens capsule, capsulorhexis is done with the help of Utrata forceps, followed by the hydrodissection, and then phacoemulsification by the stop and chop technique, and PCL implantation is done after cortical aspiration. Then pilocarpine is used to construction of the pupil and hydrostitch is done. Then I shifted superior side, and after that deeper scleral flap is dissected forward until the Slem's canal is open. Identification and opening of Slem's canal is the secret of success of NPDS. So here we can see aqueous percolation. Beyond this stage, trabecular meshwork will be identified and percolation of the aqueous humor will begin. At this stage of the procedure, aqueous humor was seen to percolate through the remaining thin trabeculodesmoid membrane. Peeling of the Slem's canal enhanced the further percolation. The deeper scleral flap then excised. The percolating aqueous will accumulate under the superior scleral flap, forming lac. This is called decompression space. Afterward, aqueous will flow into the subconjunctival space and forming the bleb through the cut end of the Slem's canal, occasionally through the supraciliary space. After that 10-0 nylon suture, metal suture that extended 2 mm beyond the superficial scleral flap was secured under the flap. Suture is non-absorbable and widely available. After that, superficial scleral flap was reposited over the metal suture and secured with the 10-0 nylon suture with without releasable suture, and knot should be buried. And conjunctiva carefully closed with a interrupted 10-0 suture. So we can say that this the simple economical step enhance the efficacy of the deep sclerotomy in lowering the elevated IOP by adding the subflap matter 10-0 nylon suture after excision of the deep scleral flap. The surgical technique is excellent in achieving the additional and adequate IOP control in this patient without use of long-term AGM, along with visual recovery as per the meet with their expectation. Thank you.
That is the single case that you have done such procedure, or you have done many more?
No, I have done about the 33 cases, and we actually compile the data, then present in the next year.
So wonderful demonstration. So I'd just like to clarify here, NPDS stands for non-perforating deep sclerectomy.
Yes.
This is supposed to be a blood-less surgery actually, because the drainage is happening internally. But in your case, we saw that the percolation of the fluid was coming out. It was, it looked like it was there was a perforation inside, and we are seeing a bleb formed. Actually, you also confirmed that. I don't know. The consensus for NPDS is that the drainage has to be internal because you're just de-roofing the Schlemm's canal and it has to percolate to the internal tubercle. But here the drainage is happening in the subconjunctival space. So nomenclature wise, I am a little bit perplexed. Like, when we call this as an NPDS, it looks like a modified trabeculectomy or something like that. You're not removing a large block of trabeculectomy here, but over the view, when you're stripping off the roof of the Schlemm's canal, I felt that the aqueous humor was coming out in quite big. It looked more like a perforating deep sclerectomy for me, in my observation.
No, I think the so when you actually deroof the Schlemm's canal, it can more percolation occur, so that this fluid is accumulated under this subscleral space. So for the subconjunctival space, sometimes this space is closed. So why this region, this suture is actually put, so this suture is slightly elevate the superficial flap, and so the percolation is subconjunctivally is occur. So why this region, the technique is very economic, because we are working in a very high volume center where the follow-up is slightly less. So why this region we can do the very economic step, because patient do not actually put the drug properly. So this is the technique, is the non-penetrating, because this is the progressive percolation of fluid and progressive reduction of the IOP, because during the trap there the sudden decompression of the globes. Why this in the region it can cause the some retinal or choroidal complication. So in this case actually we do the non-penetrating with modified technique.
Yeah, the debate here is we should have a blebless surgery. That is the reason why we do it non-penetrating, because we have a lot of complications with blebs, hypotony, bleb infections, and all those things. So that was the nomenclature. It was a sort of an issue for me.
I think the procedure is interesting, but the nomenclature I would also agree with.
Might be partially penetrating or something.
Yeah, partially penetrating. You can add another P.
But excellent video.
Excellent.
Thank you.
Thank you, Doctor.
Thank you.
Fantastic. Okay, now we move back to retina, and we start with en bloc dissection of a large retinal capillary hemangioma. Dr. Vishal Rawal, please.
A 42-year-old female patient was referred for left eye retinal vascular lesion. Fundus examination of the left eye revealed an orangish red retinal vascular lesion in the temporal quadrant with dilated feeding arteriole and draining venule associated with extensive subretinal exudation in the inferior quadrant and involving the macula. Clinical diagnosis of left eye retinal capillary hemangioma was made. The right eye was within normal limits. In this video, a newer technique of en bloc resection of retinal capillary hemangioma along with feeder vessel ligation will be shown. The surgical steps are as follows. Standard 23 gauge pars plana vitrectomy ports were secured, following which core vitrectomy was done. PVD was induced with the aid of forceps and cutter and the vitrectomy completed. Adherent membrane and epiretinal proliferation overlying the tumor area were peeled with forceps. A chandelier was secured in the temporal quadrant. A cut straight needle or 9-O-proline suture was used for ligation of the artery. The most prominent dilated feeding arteriole was identified. Using bimanual technique, double knot was applied and the artery ligated. The other feeder vessel was cauterized with diathermy. Cautery diathermy was applied 360 degrees around the tumor area. Bimanual scissors and forceps were used for the separation of the tumor from the surrounding retina. The undersurface of the tumor was adherent to the choroid and separated with scissors. Nasal sclerotomy was extended to 5 to 6 mm and the tumor was delivered by increasing the intraocular pressure. Here you see the reddish hemangioma about 4 into 3 into 2 mm in size. The sclerotomy was closed with multiple 8-O-vicryl sutures. Endolaser was done around the retinectomy site. Fluid air exchange was done and the retina settled well. Air silicone oil exchange was done. Post-operatively at 1 week, the retina was attached with laser marks as seen and silicone oil in situ. Histopathology showed mononuclear round cells with proliferating blood vessels in a fibrillary and collagenous background suggestive of retinal capillary hemangioma.
Why did you take out the whole tumor by extending the sclerotomy rather than just cutting it off?
Yeah, I think it's a good question. So this was my first case where I did perform the feeder vessel ligation along with the resection of the tumor. So after that I have performed 2 more surgeries, and in that I have kind of eaten the tumor in the vitreous cavity. So I just wanted histopathological confirmation so that whenever I remove the tumor I have the solid proof that it is a capillary hemangioblastoma. I know clinically it was a capillary hemangioma, but just for the sake of me performing the first surgery and having a histopathology confirmation, for that sake I did the en bloc resection of the tumor. Otherwise you can eat the tumor in the vitreous cavity, that should not be a problem.
Okay.
So what's the long-term follow-up of this patient?
So it's close to around 1 year now.
Okay. There is no
Still-
exudation, there is no recurrence, there is no other hemangioma.
No, still oil is there. I have not removed the oil till.
Any questions, doctor?
Thank you.
Thank you, doctor. Nice surgery and good video. Thank you very much.
Thank you.
Dr. Chaitra Jayadev, can you present your film on the retina ripples, COVID risk during vitreoretina surgeries?
This program is solely made to help the practicing vitreoretinal surgeons during COVID times and is a work of non-fiction. The authors do not have any financial disclosure in the subject matter of this film. The COVID-19 pandemic has caused a major setback across the world. The medical community is affected in more ways than one. The safety of the healthcare professional is of utmost importance as we are involved in patient care, some of whom may be positive for the infection. It has been well documented that COVID-19 can be transmitted by aerosols. So, our question was, are aerosols generated during retinal surgeries? Even if they are generated, do they pose a risk? To unravel these mysteries, we conducted a series of experiments in collaboration with the Indian Institute of Science, Bangalore. PhD scholars led by Dr. Basu from the fluid velocimetry team helped us in this setup. Shadowgraphy using a high-speed, ultra-high resolution camera which can capture 5000 frames per second, that is 100 times more than what a smartphone camera can do, was utilized to detect the smallest of aerosols possible. We conducted our experiments on enucleated goat eye with vitreous being stained with brilliant blue and used an Alcon constellation system for vitrectomy. Aerosol generation was ascertained for intravitreal injections, different gauges of trocars and cannulas, valve versus non-valve cannula for lensectomy and vitrectomy, passive and active fluid air exchange, removal of cannulas and suturing. During intravitreal injection, insertion of cannula, lensectomy and vitrectomy with both 23 and 25 gauge instruments with either valved or non-valved cannulas, we did not find aerosol generation which was confirmed on shadowgraphy. Even with a 20 gauge MVR blade, there was fluid flow but no aerosol. During active fluid air exchange, we did not find any aerosol generation. However, while performing passive fluid air exchange using a Charles flute needle, we found bubbling and aerosol generation at the exit port of the annule. As expected, under fluid air exchange with reused valve and fresh non-valve cannulas, aerosol generation showed a trajectory of 0.4 to 0.67 meters with droplet-sized 200 microns. While removing cannulas or suturing under active air infusion, bubbling and aerosols were noted. Based on our experiments, we recommend use of valve cannulas whenever possible. To avoid passive fluid air exchange, even if done, direct the exit port away from the surgeon and the assistant. To maintain air pressure at less than or equal to 30 millimeters of mercury, to stop active air infusion or clamp the infusion during removal of cannula and suturing. Last but the most important, usage of adequate personal protection is mandatory. Based on these experiments, vitrectomy appears to be a safe procedure during COVID times.
Thank you for a good video and thanks for reassuring us that we can do vitrectomy even in COVID time. Okay, but the only question was, the aerosols did come in during fluid gas exchange, right? But that fluid would have been anyway sterile inside the eye. not carrying
So-
too much of a viral load as compared to a vascularized tissue.
So there are two things here. One is the surface viral loads. We're also looking at surface because once the fluid comes out, there is some mixture with the surface, and it's already been proven that the surface does harbor, the COVID virus, and it was seen quite clearly and it was already published. So only after that information that we got, we decided to go ahead with the experiment. And even then, once you put in the betadine and once you do away the initial wash, we don't expect the viral particles to be there. But then having said that, we don't know what is the content that is there in the vitreous when you begin with. We don't know, we don't have any studies on that. So because we had to continue to operate during that period of time, and we wanted to ensure that both the surgeon and the personnel, the OT assistants are all safe, we did take a lot of precautions. We did wear the masks, the N95 whenever, and even the other bigger masks, where we could seal much better. Still, we wanted to figure out what was going on, and this was not only restricted to retina. We did it across all the other specialities as well, which is more an open surgery. Like for example, plasty. When you're drilling, you want to know whether the particles reach you, and more so because you're not closing your eyes. Your mucosa, your conjunctiva is exposed. So you can't really, unless you're wearing again a protective glass, which is probably sometimes difficult while operating. That's the reason we
So you are assuming that the virus particles are on the surface of the eye, the surface of your instrument being used?
No,
or in
surface
vitreous
of the
cavity?
eye only. Surface of the eye. So when the fluid comes out, if it mixes with and you carry a viral particle, there is possible exposure.
But that experiment was done in 2020 when it started.
Yes.
She said it.
But later on the CDC confirmed that fomites are not a very significant source
Not
of
fomites, I'm talking only about the
On the surface,
conjunctiva,
on the
surface
surface
of the eye, not the instrumentation. Only the conjunctival sac, because they did see a lot of viral load on the conjunctival sac.
Beautiful photography, and we could see that the aerosol generation was coming. And did you measure what is the distance at which it stopped actually? So that the safe distance for the surgeon or the assistant?
So that actually depends on the size of the droplets. So the heavier the droplets, they fall down rapidly because of the gravity. Whereas the smaller droplets are the ones that can carry up to 0.67 meters is what we saw in our experiment based on the trajectories. And how we did the experiments is that we did each of these procedures at least 5 times. Only after 5 times, if we didn't see any aerosols, we told that okay, this particular step does not create any aerosols. We also different air pressures also we checked, because we thought probably higher the air pressure, more will be the push. So the trajectory was up to 0.67 for the potential aerosols that can carry the virus.
Wonderful.
Thank you.
Thank you.
Thank you.
so much.
Wonderful.
Next, we have Dr. Mimansa Agasti, and she's going to present on innovative models for vitreoretina training during COVID times.
Good afternoon and regards to everyone. Can we play the video, please? 106.
Cookies तो रहेगा ना जार में।
Innovative models for vitreoretinal training during COVID times.
COVID times have really been stressful for all healthcare workers and medical fraternity. Of all the affected domains, learning and residency seem to have taken a back foot. In this regard, vitreoretinal training, that is lasers and surgery, have been affected mostly. Simulator-based learning is very important for skill transfer both for surgery and lasers. The basic orientation for a fellow to begin laser is the inverted and laterally reversed image seen through the contact lens and focusing the aiming beam on the retina. There are very few eye models for practicing retinal lasers. Commercial eye models do not cater to disease-specific learning and are expensive too. We describe a simple, customized and cost-effective eye model for retinal lasers and VR surgery. We describe the Retilab eye model. The eyeball framework is done by cutting a ping pong ball in half. An aperture of 5 to 6 mm is made in one of the hemispheres which simulates pupil. An A4 sized drawing paper is chosen and a retinal diagram with the desired lesion is created on Microsoft Paint or similar program. The image is stored in a portable graphics format and 9 copies of the retinal diagram can be printed per A4 size paper. The retinal diagram is cut in the form of a circle. 4 slit-like apertures or wedges are made in the corners and assembled inside the ping pong ball. And regular contact lens for laser photocoagulation is used to practice lasers. The used retinal film can be replaced by a new one in the same framework. A discarded electrical junction box with a hole in the lid and the plastic tube at the other end attached is used. It is very cost effective and the burns produced resemble those on human retina and power settings are comparable to real life scenario. Focal, grid, barrage lasers can also be practiced on the same. Wet lab eye models have been the traditional approach but has its own limitations like availability of eyeballs and the instruments cannot be used on human eyes again. Simulators are very expensive and not available in all centers. We have designed a simple, cost-effective and practical eye model, Retisurge. The model eye is designed by 3D printing. An eyeball is sketched for its anatomy and incorporated into a software with appropriate dimensions. The model eye is consisting of 2 hemispheres. The upper one is made of TPU, thermoplastic polyurethane, which has the same elasticity as sclera and is flexible. And lower one is made of PLA, polylactic acid. A color printed sheet is folded into hemispheres based on the concept of K-comb wrapping and traced and customized using a 3D printer. The same is used on the printout so that it fits perfectly onto the eye model. For a realistic image, polyethylene terephthalate glycol sheet (PETG) sheet can be used instead. A microscope handle cover is fitted into a cardboard box with a hole at the center and the eye model is placed over it. 2 ports that simulate sclerotomies can be made in the superior part using a trocar that allow introduction of instruments into the posterior segment. This assembly is then used in conjunction with the operating microscope fitted with a biome to allow stereoscopic view and practice various steps of VR surgery. It is cost effective and can be practiced inside the operating room with available instruments. The practice of non-dominant hand maneuvers and flexibility can also be done using the eye model. The basic concept of core vitrectomy is vitreous removal without losing focus of microscope. Endolaser can be practiced on the PETG film which produce burns comparable to human retina. It also creates a sense of awareness of instruments inside the eye to avoid touch. It also decreases anxiety and complications and improve performance. In conclusion, these 2 innovations are simple, cost-effective, reproducible and have helped a long way in VR training during COVID times. Thank you.
It's an interesting and economical way.
Thank you, sir.
So, we can even print the various pathologies that way and
Yes, sir, we can
just
print.
ask anyone to laser that
Yes,
rather
sir.
than just do drawing also.
Yes.
Today, Mansa, this ping pong ball model has been presented somewhere else also? Because
So
I
we have
think-
published in IGO videos also,
Yeah,
and
that-
Dr. Pratyusha ma'am had also.
When was this presented? Any idea?
No, sir.
Regarding the model for vitrectomy which you used, the vitreous cavity presume is it empty?
Yes, sir, it's optical empty,
So
sir.
it's empty. Okay, there's
gel or
no
vitreous
gel. You're not using any
no,
gel.
sir. No, sir.
So I think basically you're trying to simulate the tissue handling when you're trying to make
Yes,
incision
sir.
sports.
Yes, sir.
That's the advantage of using that particular plastic material which you have
TPU
used?
is like we tried with ma'am and with our mentor also.
Uh-huh.
So it is more like equal to sclera. So the insertion and how to go, it is equal to, the rigidity is equal to scleral rigidity, sir. So the bottom part was PLA, but the sclera part where we make pores.
Has
was
it been
TPU.
documented before with this use of this particular polyurethane? What material you used?
So we tried with various, like our instruments department, we tried, this is plastic basically, sir. So we tried with plastic, yeah.
Well done.
Thank you, sir.
Maybe you can put some, something in the vitreous to,
Yes,
give you that
sir.
feeling. Otherwise,
Yes,
it looks good. Thank you.
Yes, sir. Thank you, sir. Thank you, sir.
Next presentation is Dr. Jyoti Matalia. All you want to know about optic nerve sheath fenestration. Dr. Jyoti.
All you want to know about optic nerve sheath fenestration. It was introduced by D. Wecker for neuroretinitis. It's a simple procedure that creates a fenestration in the optic nerve sheath whereby the target organ, that is the eye, is spared of the pressure-related effects by creating a diversion. So when is ONSF indicated? In unresolved papilledema, in either IIH or CVST. Here you need to note that the only and serious complication of papilledema is vision loss and can occur in as high as 40%. The other indications are unresolved chronic papilledema in any of the above and traumatic optic nerve sheath hematoma. But remember, it is not the first line of treatment in both these conditions. So when would you operate? In cases where there's rapidly progressing visual field loss or acuity loss, which is documented and reproducible, in a failed shunt operation or when shunt is contraindicated. But one prerequisite is documentation of subarachnoid fluid on the B scan prior to surgery. Now, why are we talking about the B scan? Let's understand the flow of the CSF. Once formed, it enters third ventricle, the fourth ventricle, and finally the subarachnoid space as is shown. And note that this space is right around the optic nerve head, just behind the globe, and it is this that we pick up. Now let me highlight the role of B-scan in ONSF. This was a patient who reported with chronic papilledema. The visual fields are completely constricted, as you can see, including the macular field, indicating that this patient will definitely need an ONSF. The patient reported on Saturday and was scheduled to undergo surgery on Monday. But because of my routine of doing a B-scan prior to surgery, we proceeded and note that there is no fluid at all, unlike the one that we saw on Saturday. And why is that? Because of the LP done on Sunday. And thereby, an ONSF was avoided. ONSF can be done either under GA or LA by the medial approach or the lateral approach. I shall be describing the medial transconjunctival optic nerve sheath fenestration. Please do not dilate the pupil. A 270 degrees medial conjunctival peritomy is performed by sitting temporally. The medial rectus muscle is hooked and isolated. Interlocking 6 cervical sutures are passed through the medial rectus muscle and the muscle is disinserted. Then a baseball stitch with a 6 cervical suture and interlocking bites is taken across the medial rectus insertion. Remember, this is the most important step in this surgery. The globe is then retracted laterally to expose the intraconal space. Here, first follow the long posterior ciliary artery, which takes us right up to the optic nerve, and then the short posterior ciliary arteries to isolate the optic nerve. Intermittently, you have to observe the pupil, look for a blood-free area, and make an entry with the angle keratoe. Note the gush of fluid. This is the technique of optic nerve sheath decompression. Thereafter, a part of the sheath is removed, performing the optic nerve sheath fenestration. The baseball stitch is then removed. The MR muscle is then sutured back to its insertion and the conjunctiva finally sutured with 8 cervical sutures. As you can see here, a patient with papilledema having 6/36 vision in both eyes and significant constriction of fields show a flattened nerve with 6/6 vision and resolution of the visual fields. Now let me try and give you certain tips and tricks to attain the best results. Now for every patient, a pre-operative B-scan is a must because prior to doing an ONSF, we have to ensure that there is the cuff of fluid, otherwise we'll be directly slicing the nerve. Highly malleable neurosurgical retractors of various sizes are used for this. They can be folded or bent the way you want to enter and fit into narrow spaces. In addition, we also use the cotton peanuts. A 10 to 15 degree angle keratome is used. This helps make a flap which can be excised and you can get a good fenestration. The baseball stitch is very important. This straddles the medial rectus. It helps visualize the optic nerve better by a good maneuvering. It is similar to the reins of a horse and helps retract the globe. As you can notice here, it helps us to keep a watch on the pupil simultaneously so that intermittently we can give relaxation to the optic nerve. Use neurosurgical patties. These are used as retractors to push the fat on either sides. And in addition, you can also use the cotton peanuts to give you the same. Here you can see the neurosurgical patty have nicely pushed the fat away, expose the optic nerve head, and you can easily go ahead and do the decompression. Now, is there a role of ONSF in atrophic papilledema? Let's look at this gentleman who came from Iran with a 6/18 path vision in the right eye and finger counting 1 meter in the left eye. He had atrophic papilledema. In spite of the 6/18 parts vision, there was a complete constriction of the visual fields. This is the 10-2. However, what you will notice here that the OCT of the optic nerve head is fine, but that doesn't indicate there is no swelling. It in fact indicates that the nerve is actually dying. So what we need to then look is the B scan and note here the amount of SAF around it, and the optic nerve head size was as high as 6 millimeters. Anything more than 3.5 is significant. In view of the significant fluid around the nerve, we plan for an ONSF. As you can notice, the optic nerve sheath is so enlarged that it can be seen even without retracting the baseball stitch. And with one go, see the amount of fluid gushing out. Then we have done a fenestration. Then with the help of blunt scissors, we break any adhesions underlying the sheath. Now, if you compare the change in the SAF from the day of surgery to 4 days, you will notice that the SAF is completely removed, which means that subsequently the optic nerve head will also resolve because this is the first sign to go. And due to the axoplasmic stasis, it takes some time for the other part of the optic nerve to flatten, which can be anywhere from 4 to 6 weeks. This gentleman has now stable vision for the last 6 months. So what is the ideal timing of ONSF in IIH or CVST? It depends on the visual loss. If it's severe, you do it before, shunt can be done later. If there is moderate to severe loss, you can do it along with the shunt. If there is only moderate loss, shunt is done first. If there is no resolution of fluid after 6 weeks, you go ahead and do an ONSF. And in mild cases, you do not do an ONSF. For systemic symptoms like tinnitus, headache, CSF diversion procedures are required, not ONSF. So to summarize, ONSF is a safe and effective method to preserve or even improve vision loss secondary to papilledema due to raised intracranial pressure. A good coordination between the neurologist, neurosurgeon and ophthalmologist is a must. Remember that vision loss is the only and severe complication, and it is only an ophthalmologist who can make a difference and salvage the vision. And this video will aid any ophthalmologist to be able to perform this procedure with ease and also guide them as to when and how to do it.
So let me just tell you the rationale of doing this video. I've been doing ONSD for the last 15 years and I get reference for a lot of places. But by the time they reach me, the patients are actually PL negative. So my idea is that this is a very, very simple technique. If you can do phaco, you can definitely do this. So the idea is that if you follow this, and I get people who watch my videos and do it, but if you follow this step by step, the tips and tricks, and you know when to do it, you can do it at your end and salvage a vision, because for neurologists and neurosurgeons, this is not important because they lose vision. There is no other neurological deficit. But if you can do this surgery, it's possible that the patient can salvage and have a good vision in his life. Otherwise, they go blind for life. Thank you.
Excellent presentation and well demonstrated surgery. It was quite good. Thank you.
I think,
please go ahead.
so you must have had a large series of
Yeah,
patients.
no, one thing I should want to say that you have to be very selective about what you do. So in my 15 years, I've done 40 cases. Because when you do it, that's one time. It's not something you can keep on doing. A lot of times the neurosurgeon said, and go ahead and do an ONSD. But unless I'm able to document a significant visual loss, because it also has its complications of visual loss, and they
The
are.
question I was going to ask
Yeah.
is, in these series, has any fenestration reversed? Like, again the edema has come back because it's all happening in the retroocular space.
Yes. No, it hasn't come back, but after doing it, they have to follow back with the neurologist. So this is only to salvage the nerve, take the pressure off the optic nerve, but subsequently the treatment of the IIH, like continuing Dimox and or anticoagulants for CVT, has to go on.
Series of 40 eyes, madam, any complications of PL negative, but teaching optic
No. The patients come with me like PL positive, PL negative in one eye and one eye finger counting.
And
So
how many eyes did not improve or did not respond to the treatment?
Yeah, so those who came with PL positive did not get back vision. Those who are finger counting 1 meter or even hand movements have got vision up to finger counting 2 meters or 3 meters.
Congratulations, Dr. Matalia. You demonstrated wonderfully well and the concepts are very clear. My question is very basic, like it is not a replacement for shunt surgery, right?
Yes,
it has to be always accompany shunt procedure. So that is that cannot be cannot be eradicated. The fenestration does not work in its alone thing. It has to be combined with the shunt procedure. The idea is you are going to prevent the optic nerve damage if you intervene early by doing fenestrations. That is the idea, right?
Yes, that's what I showed in the timing also.
Yeah, but you can't get away without shunt procedure.
Right.
Okay.
So that's why after that they have to follow with them, and if they are following up, like suppose I decide not to do the ONSD, shunt surgery is done, they follow back with me to monitor that the vision is not losing. If I have done the surgery, I'm checking the vision, same time they are followed up. So many times it happened that I have done the surgery, patients stop following up, they come back to me saying now your vision is coming down. I was like, you have to go back to your neurologist. So pushing us, having a rapport and both of them following up is very important.
Amazing.
Yeah.
Thank you so much.
Thank you. So now we come to the last video of today. I would request Dr. Prasanna Venkatesh Ramesh to present the IMGAR New Age Innovative Gameful Pedagogy of e-ophthalmology with augmented reality.
Can I have my video? VD32. Immersive photoreal innovative gameful pedagogy for e-ophthalmology with 3D augmented reality.
Light,
When
please.
COVID-19 happened, teaching in medical field shifted to e-platforms, with ophthalmology being no exception, with high demand for augmented reality. The 3D eye models were constructed with real ophthalmic images. Let us see why and how. The 3D eye models were constructed inside the Unreal Engine software, especially using true confocal fundus images for creating the posterior segment of the eye. Similarly, anatomical structures pertaining to ophthalmology, such as the cavernous sinus, was also constructed in a three-dimensional way. Unreal Engine was the software used to make the 3D models. This is a blueprint of the model. Inside the blueprint making software, you can see a white ball called the root, to which the 3D model is anchored to the AR template. Launching the IMG AR app. With the following steps, one can gain access to this gamification tool for infinite e-learning. Step 1. Download the AR template depicted by the red arrow and take a printout of it and place it on the table. AR template printout is mandatory for a successful AR experience. Step 2. Install the IMG AR app on your phone from the Google Play Store or your App Store. Then launch the app and focus your mobile camera on the AR template. The AR template should be fitted within the borders shown on the display screen for the activation of the AR model. This is an animation of the same process. Bring the mobile camera over the table and launch the app. Take a printout of the AR template and place it on the table. Bring the mobile camera to fit the AR template for the eye model to appear. By rotating the AR template, the eye model will rotate along with it. The AR template disappears when the camera is taken away from the template and reappears when the camera is brought back to the AR template. Move the camera accordingly to focus on various parts of the eye. Click Change Anatomical Structure button to view the next model. The user can access any angle of view of the 3D model by moving the camera accordingly. Real-time demonstration of the eye model in IMG AR. Here, the pedagogue is seen demonstrating the eyeball model in all the 360-degree angles to explain the anterior and posterior anatomical structures of the eyeball respectively. The left side video demonstrates the teaching class and the right side video displays the mobile view that the students visualize during the class. Customized multiple views of the same 3D eye model can be viewed by moving the camera accordingly for visualizing multiple angles such as top angle view, anterior segment and posterior segment view. For constructing the angles of the anterior chamber, we have used our patient's own real-time images as an inspiration for powerful deep teaching. All the 5 angle structures have been constructed in the AR model from the root of iris posteriorly to the Schwalbe's line anteriorly. Similarly, for constructing the fundus, we have used our own patient's real-time confocal fundus images. Pathological fundi images are also used in the AR model such as central retinal vein occlusion, branch retinal vein occlusion, and central retinal artery occlusion. This is a mobile camera live display while using IMG AR app. Once the app is launched, the normal eye model appears. By bringing the mobile forward, you can focus on the angle structures for YAG PI counseling and SLT counseling. By clicking on the splinter hemorrhage button, you can show how it looks in real time, which is a sign of glaucomatous progression, and the patient can be cautioned. Infrared images can also be accessed simultaneously. RNFL defects can also be shown to the patients in the augmented reality model. Multimodal imaging such as autofluorescence and infrared images can also be accessed simultaneously. Moving on to real-time demonstration of the cavernous sinus in IMG AR. Once the mobile camera is focused on the AR template, the 3D cavernous sinus model appears. The pedagogue can either rotate the AR template to view the model in all the 360-degree angles, or he can move himself to view the model in 360 degrees. The pedagogue can observe the cavernous sinus closely by moving the mobile forward. For pedagogical transformation, augmented reality models can open a new world of photoreal cinematic experience with gameful e-learning. 3D augmented reality is the future of e-ophthalmology, especially during the COVID-19 era. IMG AR will serve as a new age immersive 3D pedagogical tool for gameful learning. It works both on Android and iPhone platforms. It is available free of cost and it is built on advanced 3D touch interface. To conclude, the neophytes no longer have to mentally visualize the ophthalmic concepts during learning. IMG AR is a powerful cognitive tool which serves as a 3D encyclopedia where students can choose their optimal frame of choice from the 360-degree angle for viewing. It also enhances the real world with immersive gameful learning experiences by providing a digital overlay over the real world. Thank you. So this was submitted 1 year back. We started with making augmented reality, which was never done in ophthalmology for anatomical and pathological structures. By just having this AR template and a smartphone, the idea was to make augmented reality accessible to everyone, because when we talk about augmented reality, it goes into lakhs and crores of investing. But with simple Android phone, and we created this app free of cost, and this is the QR code that has been given behind. With a simple scanning of the QR code, this app can be installed. That is one thing. Second thing, most of the apps today, there are many apps in ophthalmology, but none of them use real-time images. What we started using was, we started collecting real retina images, real angle images, real sheen flood. Now we have evolved into, next year I'll be presenting that, sir. 1 year back was this video done. Real sheen flood images, real-time AIOC2022 images, and we reconstructed the eye with whatever imaging that has been done, and it is more like an atlas where we started adding more pathologies. Started adding flecked retina, diabetic retinopathy, and now moving on to from pedagogy. This is also applicable to patient counseling, where we can enhance their experience, as well as the fourth one is the diagnostics, which is recently innovated by us in 4D, sir. This is like Jarvis in Iron Man movie. Once we wear this, we have brought our modules into this also, the same modules which can be accessed with hand tracker as well. So the patient's diagnostics is also possible, where every patient can be given a 3-dimensional augmented reality case sheet, be it a OCT, be it a fundus photo, be it a gonioscopy. They can be given a case sheet which can be uploaded in their cloud. The idea is to make it accessible at a very low cost, that is free of cost. And the second thing is using real patient images. If time permits, if you are okay, I can demonstrate and show
we
the...
have some questions for you.
Yes, sir. Yeah, please.
Please, you start.
Okay.
Yes,
So
sir.
this is an atlas for student teaching, right?
Yes, sir.
You click a normal photograph of the fundus.
Yes, sir.
You click a photograph of a pathology like CRVO
Yes, sir.
or a cataract. And how long does it take to click a photograph and embed in that app?
Sir, when we start...
Is that process cumbersome?
Sir, when we started doing that, it was taking 30 to 45 minutes for getting the template ready. Now, since we have constructed the template for the fundus, template for the gonio, template for the lens, for the AIOC2022, now all it takes is an image. We have integrated the hospital database into the software. So the chair time is only 60 seconds. It's instantaneous now, because we have the codes ready. If you had seen that the blueprint was our intellectual property, since the codes are all constructed, now if, for example, I'm getting your fundus, in 60 seconds, I'll be getting your fundus hologram ready, because the base is already created. Yes, sir.
So that means that it can be used for the progression of the disease for the patient also.
Yes, sir. That's what, sir. When I submitted this video, I had an idea of only pedagogy because my models were limited. But the same application now in my smartphone, every 2 weeks we are given updates, and it is useful for diagnostics as well. Like diabetic retinopathy, before anti-VEGF injection, after anti-VEGF injection, how it resolves. In OCT sections also it's possible, sir.
The same applies for glaucoma progression as well, because
Yes.
you're taking the disc hemorrhage photograph, RNFL was visible.
Yes, sir.
The quality of the image which you put inside, I think that does play a role in the way it interprets and the clarity. Does that a role as maybe a not so clear picture? Will it not be so effective?
Sir,
So suppose the media is hazy, something like that.
Sir, even if the media is hazy, there is we can slightly enhance the images, one, and the second advantage of this is we anchor the route that I mentioned with the white ball. The routing thing is there, and with the routing thing, what we are doing is the fundus, the OCT, the color fundus, the infrared, the autofluorescence, they are all anchored. So the same fundus, by a click of a button, you can also get the OCT slices as well. So that is also now enhancer. But if the image acquisition is having a hazy media, the image will also be slightly hazy, but it can be enhanced but with the help of a filter in the fundus machine, but not, and also there is a small filter in the software. Maybe if time permits.
And what is that template which you're having?
Sir,
every time it has to be there?
Sir, initially we have 2 modules, sir, one without the template. But when we have without the template, what happens is if the case sheet pops out as a hologram in front of you, to examine it 360 degree, the doctor had to walk around it. But with the template, the advantages, we have the phone like this. We don't need to walk around like that. We can just rotate it. We can, for gonioscopy, just bend down and go in. That's why we created the template. Because if in a sitting position, if the hologram is this, I had to move around and see if I don't have the template. So that's why we created this.
So this is must for for everything what we want to see. This template has to be there?
Yes, sir. Actually, without the template also it is possible.
Yeah,
sir,
I know, I can
but
understand.
you have to walk around. So there are 2 options.
Right, okay, that's all.
It is for the users' feedback that we received. Some people felt that we had to walk around. So can you give us something that we can sit and examine it in our Android phone? That's when we didn't launch the template. Then we had the template so that they don't need to walk 360 degree or go in the top angle view.
Can we use a larger tab too, a bigger tab for the patient rather than just a
Pardon me, sir?
Bigger tab.
Yes, sir. We have now recently launched the same in a bigger display. This is now in Android phone, a bigger display.
The display is small and that can cause
yes,
some
sir.
amount
And
of
this
issues.
is the 4D technology, sir.
That you showed us.
Yes, sir. With this, what happens is your laptop will be connected. So, for example, I am connecting this. This is an AR headset, sir. So, between you and me, the holograms will appear, and we can actually dissect the structures for a posterior polar cataract with the anterior on imaging. The 360 degree slices will be got, and we can actually see the capsule in 360. We can walk around it. We can plan how do we want to go about the hydro. So all those even matters in pre-operative planning, diagnostics. Now it has evolved, sir. In the 8 months, we ourselves updated ourselves and moved forward.
The point is that you are extrapolating data over a default template.
Yes, sir.
Right. So the default template should be also of the patient. So if I come for a disease progression, you will make a template of my eye and then add on as I progress.
Yes.
Right.
Yes.
But you are using a default template or a pre-existing default template.
So the thing is, it is about this you are asking.
Yes. Yeah, that is what we want to know.
Sir, this is just a capture which is detecting so that the holograms will appear.
So the hologram is default that you have created. That's what I'm telling you.
So it is not patient.
It is not customized.
It is not patient specific.
I think
this is actually it is in a way to explain. The coding will be there. For example, if your fundus and my fundus are there, the fundus will be removed and the other fundus will be coded. So every case sheet will be generated differently. But to have a structure per se,
this is basically a visualization tool. It's not a diagnostic tool in that sense.
Yeah, if I can actually
it's a visualization tool.
Maybe with the
more for teaching, for education point of view.
This was done in collaboration with the institute or something.
No, sir. We made this ourselves, sir.
You make the app. You made the app. You
yes,
made the hologram. Everything.
We made the.
you have a degree except MS of Thermology of this, and you have a know-how of the software.
Yes, sir. Yes, sir. I was actually interested in engineering, sir, but I had a cutoff and
that's very important.
Sir, I had a cutoff and I thought I won't get it in merit, but I got my MBBS in merit.
So this requires coding and all that, right?
Yes, sir. Yes, sir. I was actually interested in engineering, but since I got through merit, my parents.
Okay. Thank you, doctor. Thank you very much. Thanks a lot.
You're the right man in the wrong place, but now you're rectifying
no, sir.
the
I'm
place.
trying to apply my things into engineering. More of why.
No. The what simple question, Dr. Vishal, and we're all interested is. See, this is you have made a standardized template. Every time we take a fundus photograph, we have to introduce that into that so that you are going to read that particular patients. Is it going to take a lot of time or what?
Sir, now with our software that we have integrated, the chart time is 60 seconds, sir.
Okay.
And it's actually an immersive experience, sir. With your permission, maybe I can just show the hologram.
No, doctor, that will give an unfair advantage.
Right,
to
fair enough, sir.
Yeah. Thank you very much.
Yes, sir.
Thank you, sir. Yeah.
Thank you. And now we are working with the lens star as well. As sir was pointing out, we are also taking the lens star and the biometry values as well. So every eye is actually customizedly being constructed. So if this is going to be a short axial length eye, this is going to be a bigger axial length eye. And with the fovea BMO axis, the fovea centration is getting plotted. The macula centration is getting plotted. If the fovea is +7 fovea BMO axis, -7 fovea BMO axis, the anchoring is all being worked in a precise way. And we have our own imaging, so this is a center of moving images that we have in our department. This is our team of 6, and we founded the department there. And the app and everything was actually done by us, sir.
Thank you. Thank you, Doctor.
Sir, Mahatma Hospital, Trichy, Tamil Nadu. Yes, sir. Thank you, sir.
So with this, we come to the end of the CS Reshmi Awards. Thank you very much for attending, and thanks to all the presenters for such wonderful, fantastic videos with fantastic concepts.
Yeah, I think you take the photographs. You take the photograph.
चलो हिसाब किताब शुरू
Now fourth one. हो गया ना आपका? पांडा sir wants to sign in. Same here.